Good evening, good afternoon, good morning around the globe. We have over 300 participants from around the globe, so each one is in a different time zone. After this lecture, I'm gonna sleep and Louis will just start the day. So I welcome you to the bi-weekly webinar from the ICOI. And I want to thank you for joining us. I will talk about the speaker, and I want to thank Dr. Al-Faraje for giving us the second lecture within 2 months. We appreciate it very much. And his topic today will be immediate loading principles and protocols that work. And he is a private practitioner as well as the founder and director of the California Implant Institute, which offers continuing education throughout advanced surgical and prosthodontic programs, including a master program and live patient surgical externship. Since 2001, more than 2,000 dentists from over 20 countries have received training at the Institute. He is on the top of all his qualifications, he is also the power behind the diplomate exam of the ICOI, and he's a part of the examiner committee, and he created most of the questions, and then he has multiple publications on these topics. So he's a fellow of the American Academy, he's a diplomate of the ICOI, and he lectured nationally and internationally. So I would love to listen to the immediate loading concept, and we are all excited. And of course, I will stay with you until the end to moderate the question. Louis, thank you very much. I want to thank Tara and Ale for putting this together, and all the participants on this webinar, thank you very much for joining us. Of course, you will see this webinar later on the YouTube channel. The new YouTube channel from the ICOI is youtube.com/ICOI dental. So everybody can see all the videos and all the archived ICOI webinars. Thank you very much and enjoy the lecture.
Thank you, Eddie, for the introduction. Thank you, everybody, for joining. We have only 45 minutes, and then I would allow roughly 15 minutes for questions and answers. I might skip a bit too fast through some slides, but since you have access to the lecture later on, you can pause to read or elaborate more on certain topics that will be covered. So I'll do my best to give you as much information as possible in the next 45 minutes, but again, the lecture does contain more information that will be probably beneficial for you to go back and go over the lecture again, because again, you have the ability to pause and go over certain slides with more time. So we're gonna talk about immediate loading. It's a very interesting topic. It started roughly in 2001, maybe, when it became more or less popular. More and more dentists started to apply the principles of immediate loading in implant dentistry. Started, of course, with single crowns and then multi-unit. And then, as you perfectly know, one of the most popular procedures in implant dentistry, and I would like to add most profitable probably, is when you do full arch with or without immediate loading. But of course, patients would rather have immediate loading prosthesis. We are living in very exciting time. Implant dentistry today is simply amazing because the digital planning, the CAD/CAM technology, and all the experience from the last 30 years, or rather 40 years. Implant dentistry started practically in 1982, the way we know it. Now we have the ability to provide full arch fixed prosthesis on the same day that we do extractions, implant placements, etc. So absolutely amazing. So immediate loading, when started, it was very new concept because when we learned how to do implants, I personally started in 1995, and obviously they told us that you have to wait, you have to go through a healing period before you can do before you load the implants. As a matter of fact, before even you place healing abutments. However, if you dig in literature, you will see that actually immediate loading started in the 60s and 70s. However, the failure rate was extremely high. That's why it stopped, and it came back again, if you will, 30 days later. If you look in literature, why they stopped the immediate loading, although really many studies and many, there was many experiments available in the literature as early as the 60s and the 70s. I put here in red color the main reasons that you see in those articles, early articles, regarding why they failed: poor healing mechanisms knowledge, incorrect occlusion, unfavorable prosthetic design, use of suboptimal materials, including the implant's shape and surface. So all those stuff that we consider basic these days, they definitely did not have enough knowledge of in the 60s and 70s and even the 80s, and accordingly, they went away from immediate loading. Are we here good? Everything sounds good? All right, so immediate loading history, as I said, after that, and for a long time, adequate healing period, after the initial failures, without functional loading thought to be the prerequisites for achieving osseointegration and long-term implant success. While some studies demonstrated that excessive micro movements at the interface threatens implant stability and disturb normal healing of the bone tissue, loading leading to differentiation of stem cells to fibroblasts rather than bone-forming cells, osteoblasts. Other studies at the same time demonstrated the opposite. The bone can also form at the interface in implants subjected to early or immediate loading, thus making further studies necessary. So again, you can pause and go through certain slides, but I want to point here, there is some evidence that early application of light load, and the keyword here is obviously light, can accelerate the fracture repair process. Fracture subjected to cyclic movements, mechanical stimulation of adequate intensity and frequency, heal more quickly than those that are not mechanically stimulated. This is from studies comparing the bone fracture to implant healing, and that was the conclusion as a rationale why immediate loading should work if the implant is subjected to a certain parameters. This is a histologic examination performed in 3 studies by Tester, Juckler, and Francetti. After 2 and 4 months of loading, revealed bone tissue of a good quality under formation. On the left, you see 2 months of functional loading, good bone quality. And on the right, 4 months of functional loading, 81.5% of bone to implant contact is shown in the slide. Osseointegration obviously has occurred. Many studies studies the radiographic analysis of submerged implant versus immediate loading implant, shows again very high success rate of immediately loaded implants when certain rules are applied, and we're going to talk about those rules. All right, so in literature you have all kind of terminology. In 2002, that's when really, as I told you, in the year roughly 2000, immediate loading started. So there was no consensus on how to how to come up with a name, if you will, for it. So in 2002, Consensus Conference in Barcelona, Spain, decided that the term immediate loading should apply to implants that are loaded in the very same day of implant placement. In 2003, Consensus and Conference in Stade, Switzerland, set a time of 48 hours after implant insertion. Up to today, since 2003, the consensus did not change. The word immediate loading is when you are loading the implants, when you are placing the temporary prosthesis within 48 hours. We are going to explain later why this very critical window that they give us only 48 hours for. Otherwise, you can call it early loading. So I suggest you can see here three terminology here that I suggest: early loading when the prosthesis is delivered within 6 to 8 weeks. That would be early loading, because if it's more than 8 weeks, that's I would call conventional loading. And then immediate functional within 1 to 3 days, because from my own experience, I think we can push those 48 hours to probably 1 more day. And then immediate non-functional loading, when you deliver the non-functional, the prosthesis that is out of occlusal contacts, also within 3 days, but without occlusal contacts. So this is my own, this is how I decide when I place an implant or implants. I would pick myself conventional loading, which is more than 8 weeks, could be up to 8 months, depends on the initial stability, the number of the implants, the size of the implant, the bone density, etc. So it could be conventional or early or immediate non-functioning. So this is the terminology. I think it's very simple to distinguish. So we're going to start our lecture with the following question: what kind of choices we have after we place an implant or implants? There are really 3 choices only. We can place cover screw, we can place healing abutment, or we can do immediate loading. Other words, place a prosthetic abutment. There's all kinds of abutments. I'm not going to name certain type of abutments, but bottom line, when you are placing a prosthetic abutment, temporary or final, and then you put on it temporary prosthesis, as I said, within 1 or 2 or 3 days at the most. We will explain later why that is extremely important, why that window is important. So 3 choices really. Sometimes you are forced to a cover screw because of the initial stability, the type of bone, etc., the size of the implant, the diameter of the implant, the location of the implant in the mouth. And then whenever possible, if you can do the healing abutment, if you're not doing immediate loading, of course, if you can place healing abutment instead of cover screw, then obviously this is the way to go, because I mean, who wants to do a second stage surgery or procedure at no charge? Because you can charge for simply uncovering the implant, removing the cover screw, and placing healing abutment. I mean, if you can, you should, but it's kind of not customary, if you will, to charge for the placement of healing abutment. So whenever possible, this is the way to go. But sometimes you want the implant to succeed. You do not want to subject the implant to any extra forces during the healing period, and taking any chances is not a good idea. That's why cover screw is indicated. So roughly 50% of implants, unfortunately, are candidate for only cover screw immediately after placement. However, the other 50% are candidate either for one-stage protocol, where you are predictably can maintain maintain a successful or end up with a successful osseointegration, although you are placing healing abutment, or you are going with functional or non-functional immediate loading, as we're going to see in a few minutes. So now we're going to subdivide the cases into single, partial, and fully and full arch cases. Not all cases are the same. So sometimes you're doing single implants, sometimes you're doing multiple implants because few teeth are missing, or there are terminal, some terminal dentition that you are removing, and those sockets are candidate for implant placement simultaneously, and you think you can do immediate loading also on those implants for this partially or about to be partially edentulous arch. And then again, we have the fully edentulous arches. So let's talk about the rules that you need to follow in order for you to end up with predictable immediate loading. So immediate loading is not a guesswork. When all rules are followed, the success rate is at least as high as waiting for 6 or 8 or 10 months, meaning it does not, if the implant is candidate for immediate loading and somehow you decide not to immediately load it because you think it's safer to nonetheless go with 1 or 2 stage protocol, well, you are wrong. If the implant is candidate for immediate loading, then subjected to a healing period will not increase the chances of success, because with immediate loading, you have 100% the same chances. So we need to know these rules and apply it to every single case. So it's not a guesswork, but it's a scientific work. Everything is science. Everything almost in the world, we are in 2020, and everything really is a science, meaning there is rules for everything, and if you follow it, you end up with very predictable way of very predictable results. You know, from driving a car to flying airplane to placing implants. I think everything is really a science, has rules. By now, by 2020, we're not experimenting with almost everything around us, and if you follow these rules, we end up with very predictable results. The room for artistry is much less. It's really almost everything, in my opinion, is a science. There is a very small room for artistry, because artistry without a solid scientific background, without evidence, it's hit or miss. So you might get lucky or you might not, and most likely you will not if you don't know the rules for whatever you're doing, from driving car to flying airplane to placing implants. So there is rules that must be followed. So listen, we want to do a predictable implant exposure. We are exposing the implant to occlusion forces, and we would like that to be predictable. So we need to know the rules that would lead to a very predictable results, and that implant would not fail. Speaking of failure, when you place implant for 2-stage protocol, sometimes you do not find about the failure until months and months later. However, maybe one of the good things about immediate loading failure is you found about it very quickly. So you place the implant, you think it's a candidate for immediate loading, you go ahead and you do the immediate loading. However, you missed some of the rules. You did not follow all the rules that apply here in this case, and you will have a failure. Failure would be initially in the form of implant mobility, obviously. And if you do about it something immediately, which is removing that implant before you develop any granulation tissues and infection, because eventually that would be the case. So if you remove it immediately, you might have the chance to place another implant, wider, longer, wider and longer, maybe this time without immediate loading, because if the first implant failed, most likely this patient, after all, was not a candidate for immediate loading, although you thought he is. So there's lots of advantages for immediate loading. I'm not going to stop at that slide. You can stop at it yourself and read why it is a good idea to do immediate loading. You will be selling more implants in your practice when you master immediate loading. And by the word master, meaning when you're doing immediate loading, it's very predictable. You have very good results. Otherwise, we have problem. So it's easier to sell. When you tell the patient, look, I'm going to pull your tooth, I'm going to put an implant, and then guess what? I don't believe in immediate loading, so we're going to give you a flipper, a removable partial for the next 6 months. Most patients might elect to go for conventional crown and bridge work, etc. However, if you are very well familiar with the rules that we're going to cover today about immediate loading, and the patient is candidate, and roughly 50% of patients, in my opinion, are candidate for immediate loading. Your job is simply to distinguish those, to recognize those 50% that are candidate, and distinguish those from the other 50%, so you have predictable outcome. And that's the point of this lecture, to create a checklist of all the rules and make sure the patient does meet all the rules on that checklist. You have to check all the boxes on that checklist, and in this case, you'll end up with predictable results, and you'll be able to sell more implants, because when you tell the patient, look, most likely, I mean, you never promise 100%, you never know how the surgery gonna go, but when you tell the patient, look, I'm gonna pull the tooth, I'm gonna place implants, and most likely in your case, sounds like 99%, not 100%, but 99%, I'm gonna end up with placing a temporary prosthesis for you. Doesn't matter, single crown, multi-unit, or even full arch. Then obviously the patient will be more up for going for this a treatment modality that you are recommending. So we're talking about single placement now, and if we don't place temporary prosthesis, other word, if we don't do immediate loading immediately on the day of the placement, quite often, as you can see here, we end up with a black triangle, because some bone loss will take place 100% if implant is not placed. If implant is placed immediately without immediate loading, okay, you might have no collapse in the bone. However, you will end up with collapse in the soft tissue without immediately superstructure on the implant, meaning temporary crown in this case, that will support the soft tissue that is supracrystal. And accordingly, even with immediate placement, if you're not doing immediate loading, then the chances for soft tissue collapsing that is supracrystal is high, and you will end up with a black triangle. So you might think, what is the point of immediate loading? I mean, we're talking about immediate loading, but why we're doing it? I mean, is it safer after all to place the implant and come back later to restore it? Of course, yes. I mean, overall, yes. I mean, you might think if 100% you're gonna load all the implants, or 100% you're not gonna load any, obviously you're gonna have more failure with immediate loading, because sometimes it's not indicated. However, the very main reason of immediate loading is the aesthetic outcome. That is the very main reason. Yes, the patient is more comfortable with having something fixed than removable, but I mean, come on, after all, for 2-3 months is not the end of the world. However, the main reason for immediate loading is the aesthetic outcome. When you do not restore the implant immediately, the soft tissue around the implant prosthesis later on, when you restore it, will never look as good as if it was restored, even with temporary prosthesis initially, immediately on the day the patient lost the tooth. So that's the main reason. Having said that, we cannot immediately load every implant, because some of these implants are not candidate for immediate loading. So we started doing implants in only healed site. The first step toward in the journey toward immediate loading was immediate placement. So we pulled the tooth, and we used to do socket grafting and wait for a few months and then place the implant. The first step was to immediately place the implant after the extraction. It turned to be very predictable as waiting for a few months to place the implant later. That was not good enough for us, because that prevented the collapse of the bone from the crest down, but did not do anything to the soft tissue. So the next step, pushing the envelope toward immediate loading, was to place the healing abutment immediately after implant, on the day of implant placement. So not only pulling the tooth and placing an implant at the same day, but guess what? Pulling the tooth, placing the implant, and putting healing abutment on the same day. And that did provide some support for the soft tissue above the crystal level. However, not good enough, because number one, the tooth cross section at the soft tissue level, not round, as you can see here. The teeth are oval shaped, totally not complete round, as you can see with all healing abutments up to today. We're in 2020, and 99% of the healing abutments available in the market are round. So this was not good enough. Plus, the papillae continue to recede because there is no support, there is no contact, as you can see in this image, between the healing abutment and the teeth next door. So the first step was very good, which is immediately placing the implant after extraction. The second step was also an enhancement to the soft tissue, supracrystal, by putting healing abutment immediately on the implant, if it is placed immediately after extraction or not, as long as it's candidate and can withstand some micro movements during the healing period. And then, of course, we went all the way to place temporary prosthesis. If you do not have problem with the concept of placing healing abutment immediately after implant placement, with or without being placed after extraction, then you really should not have problem with immediate loading at least single implant, because the rule number one for immediately loading single implant is the temporary prosthesis out of occlusion. And it's not functional. So it's really not immediate loading, it's immediate provisionalization. And it's nothing but slightly bigger healing abutment than usual, but with the advantage of the color, of much better shape, not completely circle, but taking the shape of the tooth at the gingival level. And then obviously by providing contacts with the teeth next door, you have much better chance of maintaining the papillae between the implant and the tooth or teeth adjacent to the implant on each side. So you really should not have any issues whatsoever with the concept of immediate loading, at least single implant, if you have no problem with immediate loading. It's simply a white color healing abutment that has contacts with the teeth next door and provides much better profile at the gingival level than simply a circular in shape healing abutment. So we have 9 rules that we need to apply, and your success rate with immediate loading single implant should be 97%, just like waiting 9 months to restore the implant. There is no 100%, unfortunately, in our business. In literature, we continue to see that the success of implants over time are anywhere between 95 to 98%. Many rules will influence that percentage. You know, the experience of the operator, the type of surface, the surgical technique, you know, not overheat the bone, not overcompress the bone, and the proper 3D placement, and all those surgical rules that have nothing to do now with our rules for immediate loading. So a single implant immediate loading has 9 rules. You follow those 9 rules and your success, as I said, 100% the same as waiting for months and months. So first of all, rule number 1, you need to make sure that we place the implant, we immediately load single implant in good bone quality only. When you are placing the implant in D3 or D4, then it does not matter what is the initial stability. It's not good enough. You see, so we have the good bone quality rule, and we have later on, as you're going to see, the initial stability. One of them is not good, meaning you can somehow place loose implant in good quality bone. You are new to implant dentistry and your surgical technique is not perfect yet. You did maybe a little bit too much in and out movement. You did not estimate or recognize the quality of bone you are drilling in from the first drill, second drill, with a little bit of experience, 50 implant experience maybe, you are able to tell what kind of bone you're dealing with. So you should know if you should put the implant now or you have to drill further in order for the implant to go with the proper stability without further drilling, or it requires more drilling, etc. So you can perfectly manage to place loose implant in very dense bone, obviously. So good bone quality is a must in order to do immediate loading, but it's not enough by itself. That's why it's only one of the rules. All the rules are at the same significance. Rule number 9, as important as rule number 1, I have to mention. Somehow you have to put them in a, you have to give them numbers, but the same significance. So rule number 1, you have CT scan. You should not place implants without CT scan. We are in 2020. And then on the CT scan, you can very easily measure the bone density, and it has to be a bone that is D1 or D2. The bone density would have to be good to proceed. So all kind of articles that you can later on pause and read, that they emphasize the importance of high density bone for immediate loading. They show the high failure rate when the bone is not dense. Number 2, we have to minimize occlusion forces. So no immediate loading in patients with parafunctions. You might now say, wait a minute, parafunctions, you know, that's mainly bruxism or clinching the teeth. So if the tooth is out of occlusion, what this has to do with parafunctions? Well, there's another parafunction called tongue thrusting. It does have to do with immediate loading, even if the prosthesis is a single crown on an implant, out of occlusion, non-functional. Still, if the patient has tongue thrusting, one of those parafunctions, then the patient is not candidate for immediate loading. This slide is a reminder what are the factors that affect the stress on the implants. Stress is force divided by area, the force factors that we need to minimize, and the area factors that we need to maximize in order to lower the stress on the implant. So proper implant design is very important. Rule number 3, when we say implant design, we mean 5 things: length, width, body design, thread design, and abutment connection type. So we want obviously the longer, the widest implant possible, as long as we maintain 1.5 millimeters, hopefully, on the buccal and lingual of the implant. So implant length is also very important. And my rule is you do not immediately load implants that are shorter than 10 millimeter. You are more than welcome to place implants that are 9 millimeter and 8 and 7 and 6 millimeter long. But immediately loading those implants is a no-no. You're breaking rule number, rule number 3. You're breaking that one. Then when you get failure, next time you will not do that, because you're going to review these rules and you would say, yes, I broke that rule. So you want as wide implant as possible, as long as aesthetically the prosthesis on it would still be acceptable. You can't put very wide implant in ridges that are narrow, because you need to maintain hopefully 1.5 millimeters on each side of the implant, and you need to have that nice emergence profile that wide implants do not provide, unless you're putting on a molar crowns. Length, again, the longer the better, without exception here, as long as anatomy wise you are not taking chances with compromising any anatomic landmark. Implant body design, according to literature, tapered implants are better than cylindrical for immediate loading. They have higher initial torque, higher reverse torque. You can see all those articles from the literature that I'm quoting that do deal with this issue. And now implant thread design, obviously aggressive thread design provide more implant to bone ratio, and it's what is desired. And these articles that deal with this issue that you can review later. And then last but not least, the fifth thing is the implant abutment connection. And the best connection available in the market today is the conical connection type, because what's the point if you have a very good bone, very good initial stability, long implant, wide implant, aggressive thread, tapered implants. So all those stuff that we already talked about, but yet you have very weak connection between the abutment and the implant. That would lead to too many movements on the abutments. The implant did not also integrate yet biologically. It's sitting there only with mechanical initial stability. That would also lead to the too much stress onto the implant bone interface. And of course, it would lead to implant failure, which initially present itself, as I said, in immediate loading cases with implant mobility. As soon as you have any mobility whatsoever, the implant is failed. You have to take it out, and you might be able to place implant right then and there of wider, longer, etc. Or you might have to do bone grafting and come back later, or if there is an infection already, acute infection, then you can even you will not be able even in that case to perform bone grafting. You would simply clean the socket, give antibiotics, and wait for appropriate period of time for the socket to heal, or the osteotomy rather side to heal before you can go back and place implant. Low stress areas, meaning, you know, the further we go posteriorly in the mouth, the higher the stress, because the closer we are getting to the chewing muscles. And accordingly, we need to stay away from immediately loading second molar area. Temporary crown out of occlusion, we talked about that. And this is an article dealing with the amount of micro movements that will not prohibit osseointegration from going on successfully. That's 50 to 150 micron, and with low stress area, that would help to maintain the amount of micro movement, or the force of micro movement below that threshold, if you will. Another articles dealing with this issue. Here's a third article by Brunsky, very famous article that dealing with this issue. Another one. Number 6, high initial torque. So in literature, you see the number 35. I think it's a little bit weak. I like to immediately load implants that are at 40 or higher Newton centimeter of torque, or 70 or more on the ISQ. If you have the Ostel or Penguin machines that deal with the ISQ stability measurement. Here's, as I said, in literature, you see the number 35 in many, many articles. I personally think it's a little weak. I like 40, if not 45, even for immediate loading. So you can measure the initial stability of the implant with the ratchet that comes with the surgical kit. Or obviously, better yet, if you have the Ostel machine. The newest one doesn't look exactly like this one. I need to update this image. But you screw the smart peg onto the implant with your hand at the end, the appropriate one, because they come different thread. The thread size depends on the implant internal thread, of course, size. And then it uses the resonance frequency analysis using the principles of a tuning fork. So the machine will send, if you will, magnetic pulses that will hit that smart peg. The smart peg will vibrate and sends back. That vibration is measured again by that probe without touching the smart peg that you screw, as I said earlier, with hand, with your finger pressure onto the implant. So the stronger the implant, the less vibration, or the more stable the implant in bone, the denser the bone, the good initial stability and all that stuff, the less vibration, the higher the number on the machine. And you measure usually from 2 different angles. And this is what you go by. You cannot compare it to the Newton centimeter of torque, but if you will, 70 is roughly what is 40 Newton centimeter of torque. 60 is what roughly 20 Newton centimeter of torque. Under 60, you might want to consider removing the implant. It's under very high risk. 65 to 70 is where you can do one-stage protocol, bypassing the healing abutment immediately. But 70 or more, you can do immediate loading in case other rules also are met. Other conditions are also met for immediate loading. The initial stability, as you perfectly know by now, is not the only indicator for to go ahead with immediate loading. So soft diet is very important part of the conditions to meet in order to end up with predictable immediate loading. So you can see here the mechanical stability is extremely high. That's the purple line in this graph, if you will. Goes quickly downhill, and then the biologic mobility starts 0 on the day of implant placement and then goes up if there is nothing to interfere with its success, like infection or too much micro movement on the implant. So the green line is the average between 2. So if everything is good, you still can see a dip in the stability of the implant almost immediately after implant placement. So for roughly 2 to 3 days, that's why we talked earlier about having very important not to load the implant in that after that window, which is literally 2 to 3 days at the max, because after that the initial stability, as you can see per the blue line, per the purple line, goes downhill very quickly, the mechanical one. It's too early after 2 days for the biologic one to form. So that dip between 2 days and all the way to 8 weeks, 6 to 8 weeks, in case of everything is good, the patient would have to eat very soft food. That dip can be much, much longer. So in case of immediate loading, that dip is from day 2 or 3 all the way to 6 to 8 weeks. But in case of the implant not candidate for immediate loading, that dip could be 6 to 8 months when the initial stability is very high, when the bone density is very high, when the implant does meet those 5 criteria we talked about, when we don't have parafunctions, when it is not high stress area in the mouth, then that dip is only 6 to 8 weeks where we have to eat soft food. Otherwise, immediate loading altogether is contraindicated. And even after that, we need to do progressive loading on the implant by eating soft food, even months and months after the healing period, once we expose it, in order to minimize the chances of failure of that implant due to too much stress when it still cannot handle. Cooperative patient is very important. What's the point of us meeting the 7 rules we already talked about? And guess what? The patient would leave the office and go eat on that tooth something really hard. What's the point? So if the patient is not cooperative, that's things will fail, or immediate loading will not work. Accordingly, that one of the rules that must be met, the patient should be responsible enough, understands the risk associated. The reward is having something fixed in his mouth, but the risk is that implant is yet not ready for regular consistency food, density-wise, and accordingly must eat soft food, nothing harder than mashed potato, if you will, for 6 to 8 weeks on that particular tooth, or in the entire mouth, in the case you're doing full arch. And then experience, that in particular experience of the operator in the implant system. So you really don't need experience of years and years to do immediate loading, absolutely not. I wouldn't say let's do immediate loading with your first implant, but maybe after 50 implants, if you understand the science behind and the rules behind the immediate loading, you're more than welcome to start slowly but surely doing immediate loading, initially on single implants, of course, when making sure all those 9 rules are met. It's as simple as that. So if you have 50 implant experience or 2,000 implant experience, it does not matter. Your success rate would be the same if you are following these rules, and you might do after 50 implants better results than somebody with 1,000 implant experience getting into immediate loading if he does not understand these rules, or he is reckless and not respecting these rules for predictable outcome with immediate loading. So here's, in this slide, I summarized for you the 9 rules that are required to have literally 100% success rate with immediate loading single implant. And it's really, I'm saying immediate loading, and it is not. You know, it is immediate provisionalization. Nonetheless, the implant is subjected to quite a bit more forces than those implants that are submerged. And accordingly, you have to have great respect for these rules in order to end up with predictable outcome with immediate loading or immediate provisionalization with single implants. And that's really very important, and that's really something you have to do because you will sell more implants, you will have happier patients, and you will end up with much better aesthetic outcome around your implants when you are able to immediately provide provisional prosthesis on those implants, as long as obviously by doing so you're not compromising the predictability long term of the implant therapy that you are providing for your patients. Contraindications for immediate loading here, obviously when those rules are not met, but you can go over that. Final restoration, patient instructions. Here's a quickly sample case. This tooth number 9, or for the international system, number 2-1, needs to be extracted. So sometimes you are able to remove the tooth without elevating any flap. Sometimes, unfortunately, not possible because you really need to do a good job placing the implant or the piezosurgical tip between the root and the surrounding walls of the socket. You elevate the soft tissue and remove the tooth. The bone and the patient is candidate. We place implant. In this case, happen to be anterior zone. So most of the time we have to use the Lindman drill because we need to be able to place the implant palatal. Of course, you need to make sure you have plenty of gap around the implant. So the buccal and lingual plates are no less than 1.5 millimeters. More is even better. When you are placing implant for screw-retained prosthesis, you like it or not, most likely you are placing the you have enough gap unless you really go a bit crazy with the diameter of the implant. In this case, happen to be cement-retained prosthesis, which is okay for single implants. Otherwise, definitely if it's multi-unit or full arch, the temporary prosthesis at very least must be screw-retained prosthesis for many reasons. We'll get to that. So here we go. This is taking impression, placing healing abutment for only 2 days. After 2 days, we are delivering the temporary crown, and we did close the diastema of this patient with the temporary crown. And 2 months later, you can see the soft tissue healed. We have 0 soft tissue loss. The papillae did not recede because they are supported. The soft tissue, the supracrystal, same thing. And you can see how beautiful the soft tissue is. And now we are removing the temporary prosthesis to fabricate for the patient, to deliver for the patient the permanent prosthesis. The implant abutment was scanned. It meets the diameter and the depth guidelines for aesthetic outcome. 3 millimeter. And now the crown obviously has to match the 1-1 or number 8 in shape and size. And you can see here, it's delivered again number 2-1. And now we had to do Invisalign to close that space without obviously moving the teeth, without moving the implant. Another case very quickly here, this is the patient already lost the tooth. So we already have loss in the bone and soft tissue. Nonetheless, implant was placed. We have 66 and 70 on the ISQ measurement. The implant is candidate for immediate loading, bone density wise, initial stability wise. So taking impression here, following different technique. And after 48 hours or so, delivering crown for the patient, and 4 weeks later we can deliver the final Procera crown for the patient. Now the papilla would look better in a few more weeks, but this is just showing doing immediate loading immediately after extraction, or even or as a delayed for delayed placed implant. Screw retained sample for single, and this is how it shows the out of occlusion, and this is the immediately when we place the implant fairly soon after extraction. But you can see with amount of stress within normal limits, the bone density would be better. And this is now delivering the final prosthesis 2 months later. Proper depth, proper placement, mesodistal, buccolingual, angulation wise. And here we go, the final prosthesis for implant that was immediately loaded on the day of the placement. For multi-unit implants, we have 7 rules, but those are additional 7 rules. That does not mean we forget about the 9 rules for single implants. Splinting, you have to read about the importance of splinting the implants. For multi-unit, shorter pontics, as short pontic as possible. There's no way around pontics, because not possible quite often to place implant for every single missing tooth, and there is no need even for it. And this is the rules that apply for the implant bridge, if you will, because it's multi-unit design. You know, so the design elements, the type of alloy, and the length of the span, and you can read about those biomechanical principles that will dictate the success of multi-unit fixed implant supported prosthesis. And then, of course, no cantilever. And you can read about the importance of providing a short cantilever as possible. It should be close to 0, not possible, because even if you only have 1 crown, as soon as the patient choose 1 or 2 millimeters away from the center of that implant, there is already a distance developed. And now there is some kind of cantilever, but we wanted to keep it to the minimum, especially for the temporary prosthesis. For the permanent prosthesis, in some scenarios, you can do minimal cantilevers, but on the temporary prosthesis, there is no exception. So those additional rules on the top of the 9 for multi-unit is splinting temporary crowns, as short pontic as possible, no cantilever, proper occlusion. There is no occlusion there in the single units, but the same thing here with the multi-unit. You're gonna try to take it out of occlusion, or at least absolutely no lateral interferences on working or non-working sides. That's absolute no-no in implant dentistry, as it interferes. That is very damaging to the bone implant interface with any lateral movements, forces, on the implant prosthesis. Adequate implant quantity, screw retained temporary prosthesis, and prosthetic design that will enable good oral hygiene. sample case where you can see the short pontics and no cantilever and out of occlusion and proper design for hygiene and all that stuff. It's not important really the aesthetics here. 2 to 3 months later, when the soft tissue completely healed and the implant also integrated, biologically good enough to withstand the forces of proper implant oriented occlusion, then you can switch to permanent prosthesis. For fully edentulous arches, we are going to add 5 more rules. So we have 9, we have 7, that's 16, and we're going to add some more rules for the full arch. Minimum 5 implants in the mandible, 7 in the maxilla. You might say now, well, how about all on 4? Well, all on 4 is usually not molar to molar. If you want molar to molar, then 5 in the mandible and 7 in the maxilla. You're welcome to break this rule at your own risk. Implants should be evenly spaced to distribute the forces of occlusion evenly as much as possible along all the implants. Passive, because the number of the implant is one thing, but I would rather have 4 properly spaced and placed rather than 6 that are obviously all of them between the 2 metal foramina, for example. So implant should be again as evenly spaced as possible to distribute the forces of occlusion evenly onto all implants. Passively fitting implant prosthesis. This way the implants are subject to stress only when the patient is chewing onto the superstructure. Otherwise, if we don't have passively fitting prosthesis, our implants are subject to 24/7 stress without even having any chewing forces applied onto the prosthesis. The chewing forces applied onto the prosthesis in non-passively fitting prosthesis will only be superimposed onto the stress already existing, and that might be a little bit overwhelming, and that's when the bone loss start to take place, because the amount of strain happening around the in the bone around the implants not possible to repair in a timely manner because the patient is chewing 3-4 times a day or even 2 meals a day. That would be plenty for the body not be able to keep up with the repair in this case. Proper occlusion, I cannot tell you which one. That depends on what we have opposing to the full arch we are dealing with. So we said no to lateral interferences, but obviously we have different type of occlusion that we might have to use. Anterior occlusion if we are doing immediate loading for both arches at once, or canine guidance when we are having fixed prosthesis against our full arch immediately loaded prosthesis, or maybe balanced occlusion if opposing to our full arch immediately loading prosthesis is a removable denture. So these are the rules again for that we're going to add to the 9 of the single implant, to the 7 of the multi-unit. So we will end up total with exactly 20 rules that we must follow in order to have predictable outcome with immediate loading full arch. How many patients meet those 20 rules? At least 50%. You just have to make sure the other 50% are not getting immediately loaded full prosthesis. So still plenty you can do. On the top of all these rules, you need to consider patient size, age, sex, diet, and opposing dentition. The protocols now for full arch, as most of you familiar, remove all the teeth, do adequate amount of alveoloplasty, place adequate amount of implants in size, length, and distribution. All of them should be obviously extruding through the lingual aspect of the prosthesis, and you can convert a denture. And this is converting the denture directly in the patient's mouth, as you can see here. Now, other way is to do indirect immediate loading when the lab is doing within 48 hours for you the converted denture. So in this case, I pulled all the teeth, upper and lower. I placed implants on the upper, and the uppers were not candidate for immediate loading. And as you can see here, placed 5 implants on the top, and on the lower, we had to remove these teeth and do adequate amount of alveoloplasty, placement of 6 implants. You can see the amount of bone, buccal, and lingual to each implant, and enough gap on the buccal of each to also put bone graft in. And this is indirect method by the lab for full arch immediate loading. No cantilever whatsoever on the temporary prosthesis, and this would be the patient after the delivery of the temporary prosthesis 48 hours after surgery. This will conclude our rules and for predictable immediate loading, and I would love to take some questions if I have any here. All right, let me see how to get to. All right, so I have a question here from Dr. Raoul. Hi, what about the movement of adjacent teeth, PDL related, contacting your temporized tooth? Would that cause failure? Thanks. I would say you need to, look, I mean, first rule in implant dentistry in general, not immediate loading. First rule in implant dentistry, you cannot place implants if the patient has periostatus not under control. So you really need to make sure there is no periodontitis or even gingivitis anywhere in the mouth before placing implants. So rule number 1, implants have to be placed in a healthy mouth. So you need to make sure, because the same bacteria that does cause periodontitis cause peri-implantitis. So, but not only for that reason, we need to make sure that we have stable teeth. I don't think the movement of the teeth next door would lead to a failure, but I think you need to revisit the treatment plan and have a comprehensive treatment plan, and not do implant, and not only that, but also immediately load it when the teeth next door are mobile to the point that you're worried about that. So I would say you need to, in this case, make sure you have a comprehensive full mouth treatment planning for the patient. Another question I have, sometimes after completion of immediate loading healing period, we found the implant integrating well with good bone level around, except on one proximal side, mostly distal. What do you do if couple of threads exposed? Clean and leave or GBR around these couple of threads. This is now totally different topic. I'm not sure why you're having bone loss around the distal of your immediately loading implants. I would say one possible reason, you are not placing the implants deep enough. Possible reason, you are not paying attention to the occlusion properly. That could be occlusion related. Could be oral hygiene related. If you don't have any, I don't think it could be localized infection, but this is really first time I hear this, that somehow only on the distal part of the implant, of immediately loaded implants, quite often you see that. I mean, if you're asking this question, you're probably seeing that quite often. You need to revisit your surgical technique, the depth of the implant in particular, and the occlusion. Those are the things that I can think of in this particular case. However, what you do about it, most likely I will do GBR. In certain scenarios, I would clean and leave alone, like you suggested, but most of the time I do something about it. So that would be a peri-implantitis lecture that I would love to give in the future, where you can open flap and treat the surface of the implant with antibiotic paste and or with citric acid, and then create bleeding points and do GBR, which is bone graft and membrane, release the flap and suture with primary closure. So that is a possibility, and most of the time I do something about it whenever something does not look right. If an immediate implant, another question, fails, who pays to redo the case? Thank you. Excellent presentation. Thank you very much, doctor. You pay to redo the case. I'm sorry to tell you this, but the patient will not expect to pay when he literally few days or few weeks ago paid for an implant and prosthesis. Most likely, although it might be the patient's fault, yes, I understand. He might have not listened to you and he ate hard food on it and all that stuff. But in any event, if the failure is very quick, and in immediate loading cases, most of the time the failure is very quick. Otherwise, the implant also integrated and you will not have fairly soon failure. If I understood your question correctly, but if the failure is fairly quick, the patient does not expect to pay again. So it's your job to make sure he's responsible to follow your instructions. The instructions for post-op are delivered very clearly in writing and verbally, and monitor the patients and keep reminding him about the importance of good oral hygiene, soft food. Your job to make sure the occlusion is proper for full arch or for single immediately loaded implants and all that stuff. But I'm sorry to tell you, the patient expects you to pay for it and redo it at no charge if it is soon after the implant placement. Can you splint an implant to a natural tooth? Yes, I can under certain conditions, but not in immediate loading. This is totally different topic. In immediate loading, the answer is no. But can you place implant? Let the biologic osseointegration take place and then connect to a natural tooth under certain conditions. That is okay if the alternative is much worse. So there is very few scenarios I can name, but that's a totally different lecture. That's like 20-minute talk, but in immediate loading, is a no if that's what you meant. Can you comment on Versa bone densification and PET socket shield? I do not like the PET socket shield technique, so my comment on it is I am not a fan. As for Versa bone densification, absolutely. Anything to increase the bone density and to lead to better lead to better initial stability of the implant and accordingly more predictable osseointegration, I am for. Versa bone drills are fine. But if you are thinking of denser drills for your osteotomy, this osteotomy site is not candidate for immediate loading. That's a sure thing. If you think you need denser drill to place this implant with good initial stability, this implant is not candidate for immediate loading. What is the principles of choosing quantity of implants for full arch restoration? As I said, quantity is important. The more implants, the better. That doesn't mean we need to do 10 implants. There is no need whatsoever. So the minimum are 4, but more important than the quantity is the location of the implants. I would rather have 2 in the molars, in the first molar sites, and 2 in the canine sites, rather than 6, all of them between the 2 mental foramina. But if you ask me about the optimal minimum, would be 2 in the first molar, 2 in the first premolar, and 1 in the central incisor. It doesn't matter, right central, left central, and then 4 in the posterior. First premolar is a posterior. Whenever we have central fossa in the tooth and not cingulum, it is a posterior tooth in implant dentistry. So if you tell me what is your minimum optimal, I would say 5, 2 in the first molars, 2 in the first premolar, and 1 in the center, either of the midline, which is right central incisor or left central incisor. Next question, if you did not meet your rules in single tooth immediate loading, will you do removable partial denture? No, I mean, you can, but the answer is no. The best thing to temporize a patient who is not candidate for immediate loading is to have something like snap-on, meaning fixed, but is not touching, but there's no chance it will touch the implant or will touch the soft tissue. When you deliver removable, per your question, then you will have definitely a pressure, if not on the implant, on the soft tissue. That would lead to soft tissue depression, and you will not end up with good soft tissue aesthetic outcome around the implant prosthesis in the future. So if you do not meet the single tooth immediate loading, the best temporary, if possible, is to do something like snap-on, where you make sure that it is sturdy enough, aesthetically acceptable enough, and definitely will not touch not only the implant, but it will not get any near the soft tissue. There is some little bit of clearance between it and the soft tissue, so we do not cause any pressure on the soft tissue during the healing. I think I answered all the available questions to me on the screen.
Thank you very much for an excellent presentation. For all the people who want to know about CE, you have to send an email to tara@icoi.org. And this course will be available on YouTube, ICOI YouTube channel, youtube.com/ICOI dental in one word.
Eddie,
So
thank you
I
for
hope
the
to see you in
opportunity.
2 weeks.
Thank you,
And,
Eddie, for the opportunity. It was my pleasure to join the ICOI webinar series. And I thank you again for the invitation.
It's always a pleasure to have you. And I heard you want to talk about complications and periimplantitis.
Yeah, I would love to do that for you.
Have all of you a wonderful day, wonderful night, and hope to see you again in 2 weeks.